So for today's video, we're going to be talking about two of those special tests that we utilize and rely on for looking at the integrity of primarily the ACL, but also some of the surrounding tissue as well, to include our collateral ligaments as well as the integrity of the capsule. You'll see that momentarily with the second test. To begin with, we're going to look at arguably one of the most popular special tests that we utilize for assessing the integrity of the ACL, and that is the Lachman's. Now, there's a variety of ways that have been described to perform the Lachman's. Ultimately, the important piece is that you are providing an anteriorly directed force on the tibia in a relatively quick fashion. The second part is the position, and that being an unlocked knee. You can either do this with positioning the individual's thigh on kind of your thigh and then relaxing the leg down, or if you have a bolster handy like a foam roll or something along those lines, you can also rely on that and utilize that to also position the thigh. Ultimately, you're looking for somewhere around 20 to 30 degrees of knee flexion, so we'll show both. In this position, I have the individual's thigh supported by my thigh, leaving the knee relatively relaxed. Ultimately, I need to stabilize here as I deliver an anterior force here. And so Lachman's is done quickly, and you're assessing for excessive anterior translation. Unfortunately, swelling, muscle guarding, or an anticipation of this extra laxity can oftentimes limit the degree of translation. And so this is one that's done relatively quickly after an injury occurred, so this may be an on-field assessment, or it can also be done in the operating room under the presence of anesthetics where an individual is no longer guarding, or after that initial acute swelling inflammatory response has subsided. And so this is what it would look like. We're going to stabilize here. This side will be our mobilizing hand. We're going to approximate it just distal to the joint line, and then we're going to provide a very quick anterior directed force. Now, hand size does matter with this. If you have a smaller hand, you may not be able to fully get it around kind of the lateral and medial gastroc heads. And so what you can do then is you grab a bolster, slide this under, allow the involved leg to be relaxed, and now you can use this to help stabilize, and now you have both hands available to perform the Lachman's. Essentially, it becomes an anterior drawer test at this point. If I'm stabilizing here, it is a little awkward to get my hands in, and so I may just kind of widen my stance a little bit. I have both hands available here. I can grab and provide that very quick anterior directed force. So you kind of have two options. Additionally, if there's an aide or someone else nearby, you might have them help to kind of support or stabilize here. If the individual is small enough, say for example, you're working with a smaller, petite high school female, you may be able to use your hands and not have to accommodate through that secondary position. As we saw with our anterior drawer, we're really looking for in excess of approximately 5 millimeters of translation in the anterior direction with that test. The second test that we're going to look at is what's known as the anterior rotary instability test, or otherwise known as Slocum's. And for this one, we're going to be a little bit closer. The position is approximately 45 degrees of hip flexion and 80 to 90 degrees of knee flexion. Now there's two positions for this test. You'll notice I'm going to sit on the individual's foot just to stabilize, but essentially the two positions are this. I'm going to demonstrate it with my hand here. We're going to go lateral by about 15 degrees, and then we're also going to go medial in terms of rotation by about 30 degrees. Now, I should note, we don't want to over-rotate medial or over-rotate lateral, as what that will end up doing is creating a tautness or overstretching the capsule of the knee. And in doing so, that's actually a secondary restraint to this whole process. And so we really want to be within that arc of motion of 45 degrees, from 15 degrees lateral to 30 degrees medial. And so the first position is this. We're going to rotate our individual approximately 30 degrees medial. And if you need to grab a goniometer to check that measurement, that's okay. It hopefully is still in your back pocket, and you can quickly assess to make sure that you haven't over-rotated them. From here, you're going to stabilize by actually sitting on the foot, and then you're going to provide an anterior directed force. All right, so much like performing an anterior drawer test. What you're assessing for is if movement occurs primarily on this lateral side, meaning it moves first and farthest, right? So we apply that force in an anterior direction. If the lateral side moves first and farthest, we really have three possibilities here. One, the ACL could be implicated, that's why we're getting that translation. Two, the LCL, lateral collateral ligament, could be implicated, and that's why the lateral side is more unstable or hypermobile than our medial side. Or three, another secondary restraint we find on this side is the iliotibial band, that distal insertion. So we have to consider all three of those in our rotary instability metric here. Secondly, we're going to rotate our individual about 15 degrees lateral. This is our second position, and it's more looking now at the anteromedial side of the knee. Again, we're going to draw the tibia forward in that anterior direction. Again, looking for where movement occurs first as well as farthest. And here, if it primarily is occurring on the medial side, our involved structures could again be the ACL, which checks that anterior translation, but second of all, our MCL, medial collateral ligament. And keep in mind that the ACL and the MCL are two of our terrible triad. The only piece that we're missing here would be our medial meniscus. And so very often we find that the ACL and the MCL are both implicated in this type of pathology. Do execute some caution to not over-tighten those structures by over-rotating, as that can lead to a false negative where the capsule begins to restrict the motion and not actually the structures that we're looking at, that being the ACL, MCL, LCL, and secondarily the ITB. So, Lachman's and Slocum, otherwise known as anterior rotary instability. Complete these with a peer or colleague, have a go of them, and let me know if there's any questions.